I think you all know the normal structure of thyroid anatomy. Embryologically, the thyroid gland arises from a midline invagination at the root of tongue and grows downward in front of trachea and thyroid cartilage to reach its normal position. The weight of thyroid gland is 15 to 40 grams. Taxation of thyroid yellowish translucent. Histology, the thyroid is composed of lobules of colloid-filled spherical follicles or acini. They are lined by cuboidal epithelium with numerous fine microvilli extending into the follicular colloid that contains the glycoprotein thyroglobulin. Function, the major function of the thyroid gland is to maintain a high rate of metabolism, which is done by T3 and T4. The thyroid is one of the most labile organs in the body and responds to numerous stimuli such as puberty, pregnancy, physiology, stress, and various pathologic states. So under normal condition, the epithelial lining of the follicle may show changes in various phases. Number 1 is resting phase, number 2 is secretory phase, number 3 is resorptive phase. The synthesis and release of the two main circulating thyroid hormones, T3 and T4, are regulated by hypophyseal thyroid stimulating hormone, TSH, and involve the following steps. Number 1 is iodine trapping by thyroidal cells. And number 2 is oxidation of the iodide. Number 3 is iodination. And number 4 is coupling of MIT and GIT in the presence of thyroid peroxidase forms T3 and T4. Now the functional disorder. Number 1 is hyperthyroidism or thyrotoxicosis. Number 2 is hypothyroidism. Hyperthyroidism and hypothyroidism. Now hyperthyroidism. Hyperthyroidism, also called thyrotoxicosis, is a hypermetabolic, clinical and biochemical state caused by excess production of thyroid hormones. The condition is more frequent in females and is associated with rising both T3 and T4 level in blood. Disorder associated with thyrotoxicosis. Number 1 is primary, number 3 is secondary. Primary, diffuse hyperplasia or Graves' disease, hyperfunctioning toxic multinodular goiter, hyperfunctioning toxic adenoma, iodine-induced hyperthyroidism, neonatal thyrotoxicosis associated with maternal Graves' disease, and among the secondary, TSH-secreting pituitary adenoma. And there are few disorders which are not associated with hyperthyroidism. Number 1 is granulomatous thyroiditis or deep vein thyroiditis. Number 2 is subacute lymphocytic thyroiditis. Then struma ovarian, then factitious thyrotoxicosis. The most common cause of thyrotoxicosis are associated with hyperfunction of the gland, include diffuse hyperplasia of the thyroid associated Graves' disease, hyperfunctional multinodular goiter, and hyperfunctional thyroid adenoma. Now the clinical features. Excessive levels of thyroid hormone result in an increase in the basal metabolic rate. The skin of the thyrotoxic patient tends to soft, warm and flushed because of increased blood flow and peripheral vasodilation. Then cardiac manifestation. Among the earliest and most consistent features is cardiac manifestation. Individuals with hyperthyroidism can have elevated cardiac contractility and output, a response to increased peripheral oxygen requirement, tachycardia, palpitation, and cardiomegaly are common. Arrhythmia such as atrial fibrillation occur frequently. Some individuals with thyrotoxicosis develop reversible left ventricular dysfunction and low output heart failure, so-called thyrotoxic or hyperthyroid cardiomyopathy. Then overactivity of the sympathetic nervous system produce tremor, hyperactivity, emotional lability, anxiety, inability to concentrate, and insomnia. Proximal muscle weakness and decreased muscle mass are common. That is called thyroid myopathy. In the GI system, hypermotility and reduced transit times lead to hyperdefecation, not to be confused with diarrhea. It is only hyperdefecation, not diarrhea. Ocular changes often call to attention to hyperthyroidism. A wide staring gaze and leg lag are present because of sympathetic overstimulation of the superior tarsal muscle, which functions alongside the levator palpebral superioris muscle to raise the upper eyelid. However, true thyroid ophthalmopathy associated with proptosis occurs only in Graves' disease. So this is a wide-eyed staring gaze caused by overactivity of the sympathetic nervous system. The skeletal system is also affected. Thyroid hormones stimulate bone resorption, increasing cortical bone porosity and reducing trabecular bone volume. The net effect is osteoporosis and an increased risk of fractures. Other findings include atrophy of the skeletal muscle with fatty infiltration and focal interstitial lymphocytic infiltrate, hepatic fatty change leading to mild hepatomegaly. Then what is thyroid storm? Thyroid storm refers to the abrupt onset of severe hyperthyroidism. This condition occurs most commonly in patients with Graves' disease and probably results from an acute elevation in catecholamine levels, as might be encountered during infection, surgery, cessation of antithyroid medication, or any form of stress. Patients are often febrile and present with tachycardia out of proportion to the fever. Thyroid storm is a medical emergency. A significant number of untreated patients die of cardiac arrhythmia. Now the lab findings. Lab findings that support the diagnosis of hyperthyroidism include a low TSH value accompanied by increase in free T4. So, increase in free T4 and TSH value will decrease. Decrease TSH value, increase T4 and T3 value. This is the main finding of hyperthyroidism or thyrotoxicosis. The measurement of serum TSH concentration is the most useful single screening test for hyperthyroidism. So, the most important test is measurement of serum TSH concentration. This is the most important test because its levels are decreased even at the earliest stage when the disease may still be subclinical. In occasional patients, hyperthyroidism results predominantly from increased circulatory levels of T3, that is called T3 toxicosis. In this case, free T4 level may be decreased and direct measurement of serum T3 is useful. So, in some patients, increased circulating level of only T3 level will increase. That is called T3 toxicosis. Now, Graves' disease. That is called diffuse toxic goiter. Number one is hyperthyroidism. Number two is diffuse thyroid enlargement. and 3 is ophthalmopathy. These are the 3 features of Graves' disease. So, hyperthyroidism or thyrotoxicosis and diffuse thyroid enlargement and ophthalmopathy. Then the etiopathogenesis of Graves' disease. Graves' disease is an autoimmune disease, and as already stated, there are many immunology similarity between this condition and Hashimoto's thyroiditis. Number 1 is genetic factor association. Graves' disease has genetic predisposition. A familial occurrence has been observed. Susceptibility to develop Graves' disease has been found associated with HLA-DR3. Hashimoto's thyroiditis has both HLA-DR3 and HLA-DR5 association. CTLA4 and PTPN22. These 3 genes are involved. Number 1 is HLA-DR3, number 2 is CTLA4, and number 3 is PTPN22. A T cell regulatory gene that is called PTPN22. Number 2 is autoimmune disease association. Graves' disease may be found in association with other organ-specific autoimmune disease. Hashimoto's thyroiditis and Graves' disease are frequently present in the same families, and the 2 diseases may coexist in the same patient. That is Hashimoto's thyroiditis and Graves' disease are frequently present in the same families because both are autoimmune disorder, Hashimoto's thyroiditis and Graves' disease. And the 2 diseases may coexist in the same patient. Number 4 is autoantibodies. In Graves' disease, a TSH receptor autoantigen is the main antigen against which autoantibodies are directed. Number 1 is thyroid stimulating immunoglobulin or TSI. TSI binds to TSH receptor and stimulates increased release of thyroid hormone. Then number 2 is thyroid growth stimulating immunoglobulins, that is called TGI. So number 1 is TSI, number 2 is TGI. It stimulates proliferation of follicular epithelium. Then number 3 is TSH binding inhibitor immunoglobulin, TBII. It is inhibitory to binding of TSH to its own receptor. Depending upon its action as inhibitory or stimulatory to follicular epithelium, it may result in alternate episodes of hypo and hyperthyroidism. So, the autoantibodies involved in Graves' disease, number 1 is thyroid stimulating immunoglobulin, TSI, TGI, thyroid growth stimulating immunoglobulins, and TSH binding inhibitor immunoglobulins. Now the morphologic features. Grossly, the thyroid is moderately diffuse and symmetrically enlarged and may weigh up to 70 to 90 grams. Histologically, epithelial hyperplasia and hypertrophy are seen by increased height of the follicular lining cells and formation of papillary infoldings. Then colloid is markedly diminished. Stroma shows increased vascularity and accumulation of lymphoid cells. This is the histological pictures of Graves' disease. These are colloid deficient follicles, these are epithelial hyperplasia, and these are papillary infoldings. Now the clinical features. Patients are usually young women who present with symmetric moderate enlargement of the thyroid gland with features of thyrotoxicosis, ophthalmopathy, and dermatopathy. These are the three important features: thyrotoxicosis, ophthalmopathy, and dermatopathy. Ocular abnormalities are leg lag, upper leg regression, scare, weakness of eye muscle, and proptosis. In extreme cases, the legs can no longer close and may produce corneal injuries and ulceration. Dermatopathy in Graves' disease most often consists of pretibial localized myxedema in the form of firm plaques. That is called pretibial myxedema. Now, goiter. The term goiter is defined as thyroid enlargement caused by compensatory hyperplasia and hypertrophy of the follicular epithelium in response to thyroid hormone deficiency. The end result of this hyperplasia is generally a euthyroid state, in contrast to thyrotoxicosis occurring in diffuse toxic goiter or Graves' disease. Though at some stages there may be hypo or hyperthyroidism. The two morphologic forms of goiter are distinguished: diffuse goiter, that is called simple non-toxic goiter or colloid goiter. Then number two is nodular goiter or multinodular goiter or adenomatous goiter. Multinodular goiter is associated with thyrotoxicosis, and simple non-toxic goiter associated with hypothyroidism. Now the pathogenesis of goiter. The pathologic mechanism of both forms of goiter can be considered together, since nodular goiter is generally regarded as end stage of long-standing simple goiter. The fundamental defect is deficient production of thyroid hormones due to various etiologic factors described below, but most common is dietary lack of iodine. Main reason is dietary lack of iodine. Deficient thyroid hormone production causes excessive TSH stimulation, which leads to hyperplasia of follicular epithelium as well as formation of new thyroid follicles. Cyclical hyperplastic stage followed by involution stage completes the picture of simple goiter. So, pathogenesis of simple and nodular goiter: iodine lack of iodine, and due to some goitrogen, deficient thyroid hormone production, excessive TSH stimulation, cyclic hyperplasia involution, diffuse goiter, then repeated hyperplasia involution, and this produce nodular goiter. Diffuse goiter or simple non-toxic goiter or colloid goiter. Diffuse non-toxic simple or colloid goiter is the name given to diffuse enlargement of the thyroid gland, unaccompanied by hyperthyroidism. So diffuse goiter or simple non-toxic goiter is mostly associated with hypothyroidism. Most cases in a state of euthyroid, though they may have passed through preceding stage of hypothyroidism due to inadequate supply of iodine. Etiology: endemic goiter, prevalence of goiter in a geographic area in the more than 10% of the population is termed endemic goiter. Such endemic areas are several high mountainous regions far from the sea where iodine content of drinking water and food is low, such as in the region of the Himalayas. Goitrogen, which are called goitrogen, these substances interfere with the synthesis of thyroid hormones. These substances are drugs used in the treatment of hyperthyroidism and certain items such as cabbage, cauliflower, cassava root. Sporadic goiter, non-endemic or sporadic simple goiter, is less common than the endemic variety. In most cases, the etiology of sporadic goiter is unknown. These include following: suboptimal iodine. So, the etiology of goiter is decreased iodine content of the drinking water and food. So, now morphologic features. Grossly, the enlargement of the thyroid gland in simple goiter is moderate, symmetric, and diffuse. Histologically, two stages are distinguished. Number one is hyperplastic stage, is the early stage and is characterized by tall columnar follicular epithelium showing papillary infolding and formation of small new follicles. Number two is involution stage, generally follows hyperplastic stage after variable period of time. This stage is characterized by large follicles distended by colloid and lined by flattened follicular epithelium. So this is the colloid filled cyst. These are all colloid. And these are normal thyroid. This is the picture of simple goiter. Now nodular goiter or multinodular goiter. Nodular goiter is regarded as the end stage of long-standing simple goiter. It is characterized by most extreme degree of tumor-like enlargement of the thyroid gland and characterized by nodularity. That's why called multinodular goiter. The enlargement of gland may be sufficient to not only cause cosmetic disfigurement, but in many cases may cause dysphagia and choking due to compression of esophagus and trachea. Multinodular goiter produce most extreme thyroid enlargement and are more frequently mistaken for neoplasm. Etiology: epithelial hyperplasia, generation of new follicles, and irregular accumulation of colloid in the follicles all contribute to produce increased tension and stress in the thyroid gland, causing rupture of follicles and vessels. This is followed by hemorrhages, cystic changes, scarring, and sometimes calcification, resulting in development of nodular pattern. Morphologic features: grossly, the thyroid in nodular goiter shows asymmetric and extreme enlargement, weighing 100 to 500 gram or even more. The 5 cardinal macroscopic features: number one is nodularity with poor encapsulation, fibrous scarring, hemorrhages, focal calcification, and cystic degeneration. This is the gross image of multinodular goiter. These are the cystic changes and areas of fibrosis. This is the picture of simple goiter. These are colloid and these are flattened lined epithelium. Cut surface generally shows multinodularity, but occasionally there may be only one or two nodules. Partial or incomplete encapsulation of nodules. The follicles varying from small to large and lined by flat to high epithelium. A few may show micropapillary formation. Number 3 is areas of hemorrhage, hemosiderin-laden macrophages, and cholesterol crystals. Fibrous scarring with foci of calcification, macrocystic changes. The microscopic appearance include colloid-rich follicles lined by flattened, inactive epithelium and areas of follicle hyperplasia. Clinical features: the dominant clinical features of multinodular goiter are those caused by mass effects in addition to their cosmetic effects. Goiters may cause airway obstruction, dysphagia, and compression of large vessels in the neck and upper thorax. That is called superior vena cava syndrome. Then thyroid adenomas. Adenomas of the thyroid are typically discrete, solitary masses derived from follicle epithelium, and hence they are also known as follicular adenomas. In general, follicular adenomas are not forerunners to carcinomas. Nevertheless, shared genetic alterations raise the possibility that at least a subset of follicular carcinoma arises in pre-existing adenoma. Pathogenesis: Somatic mutations that lead to constitutive activation of the TSH receptor signaling pathway are found in toxic adenomas and toxic multinodular goiter. Gain of function mutations, most often in the gene encoding TSH receptor and less commonly GNAS or alpha subunit of gene. GNAS cause follicular cells to secrete thyroid hormones independent of TSH stimulation. That is called thyroid autonomy. Microscopically, the constituent cells often form uniform appearing follicles that contain colloid. The neoplastic cells show little variations in cell size, shape, or nuclear morphology, and mitotic figures are rare. Occasionally, the neoplastic cells are acquired brightly eosinophilic granular cytoplasm that is called oxyphil or Hurthle cell change. The hallmark of all follicular adenoma is the presence of an intact, well-formed capsules encircling the tumor. Careful evaluation of the integrity of the capsule is therefore critical in distinguishing follicular adenoma from follicular carcinoma, which demonstrate capsular or vascular invasion. So capsular or vascular invasion if present, then it is called carcinoma. If absent, then it is called thyroid adenoma. These are the pictures of thyroid adenoma. So here you can see compressed thyroid tissue, normal thyroid tissue. These are the capsule and these are the mixed stroma.